This patient, their head is still attached to their spine. All right, this is a 76-year-old female with 5 to 6 weeks of increasing numbness and tingling in her left greater than right arm, along with difficulty with fine motor function and balance issues. Her past medical history was significant for insulin-dependent diabetes mellitus, hepatocellular carcinoma, hepatitis B, hypertension, and obviously cervical stenosis. Her past surgical history, she did have a liver transplant for the hepatocellular carcinoma and a hysterectomy. She's on some immunosuppressants as well. Her exam, she was 5 out of 5 in her upper extremity. She did have difficulty with tandem walk, poor grip release. She had a positive Hoffman on the left side. Downgoing Babinski and clonus was minimal. Her sensation was diminished in her bilateral hands and intact in her lower extremities. Here's an AP and lateral of her cervical spine showing some neutral alignment, and then on the flex X view, she's able to achieve lordosis. She does have some spondylitic changes throughout the cervical spine and some disc space collapse at C5-6. She came to us with an MRI, and you can see the sagittal view as well as the representative axial views. She's shown multi-level cervical stenosis. There's significant cord compression at C4-5, as well as C6-7 with myomalacia at worse at C4-5. And given that significant amount of dorsal compression, there was concern for some ossification of the ligamentum flavum, and a CT was obtained. And this is C6-7. Here we have a sagittal CT and axial CT showing this ossified ligamentum flavum at C4-5 and C5-6 and 6-6-7. So at this point, I wanted to open up the floor, similar to the case yesterday. But so when in the discussion with my attending, who does a lot of laminoplasties, obviously we were considering laminoplasty versus posterior cervical fusion, weren't sure there was a role for an anterior procedure. So his concern with laminoplasty is that the ossified ligamentum would tether when you're hinging, and then later on it may cause a dural tear that you didn't know about, or even intraoperatively cause an unnecessary dural tear with the laminoplasty. So I wanted to hear everyone's opinions about a case like this.
Zoe?
So I think the point about the ossification of the ligamentum flavum is reasonable, but honestly, I think this patient is probably still a good candidate for laminoplasty because you're going to open on that side, and you're going to be able to see that calcified ligament that you want to get out. So you're going to get the decompression by doing that. And I see that the ligament looks like there's some partial calcification onto the left side, or what I would think would be the hinge side, but I honestly think it's unlikely that would be a problem. So I would say laminoplasty.
Brian, what about you?
It's interesting. I did this case last Thursday with an ossified flavum, and you can just reach underneath with a pen field or a ball tip on the side of the opening for the plasty, and it separates. It's interesting. We saw this case also yesterday.
Yeah.
Was this the same case as yesterday? Because I don't actually see that badly ossified that much. Usually it's more like the bottom level where it's kind of calcified.
Yeah, it's a different case.
But I think you could reach underneath. And I'll also make a plug. I do like laminoplasty for this, but I'll make a plug for doing a C3 partial laminectomy or full laminectomy for 2 reasons. We talked about it yesterday. I used to do a plasty of 3, but there's lots of good literature now that suggests when you elevate the C3 lamina, the lamina portion comes up, and the C2 edge impinges an extension on C3. So people get more axial neck pain. That's been shown in the literature. And it's also been shown in literature that if you do a C3 laminectomy, they get less posterior neck pain and better range of motion. So I'm a really big fan of doing that. And I think...
So you do a full laminectomy?
If you need it. In this case, you probably don't, but typically you would need it. And I also think it requires less exposure. I mean, the reality is no matter how much you're trying to preserve the muscles, exposing laterally at C3 to get that plate on, you have to expose much more of C3 to get a plate on than you do to just do a small 18 millimeter or 22 millimeter midline laminectomy. And lastly, the thing I really hate about laminoplasty is it really does not pay well. It really does not pay well. And it's rare that you get a win-win, but you can actually bill a primary 63051 for the C3 laminectomy, which pays separately as a work RVU, or 63001, which pays separately as a 63051 for the plasty at a separate level, which is nice. So it's kind of a win-win, but I do like the C3 laminectomy along with the plasty.
Can you go back to exercise?
Yeah.
Yeah. Along with those comments, the other thing I like about C3 laminectomy is if you're going to do a laminoplasty of C3, often 2 is kind of shingled on 3, and so you have to remove a little bit of 2, and that means a little more exposure of 2, et cetera. And the more you expose 2, the more likely it is they're going to lose some lordosis. And so there's some studies as well that show that if you do a laminectomy at C3 and really completely preserve the C2 attachments, they're going to lose less lordosis. Alpesh, you got a comment?
I was going to ask a question because we don't have as much, I think, collective knowledge and experience on ossification of the ligamentum flavum as we do about OPLL, right? And so with more profound OPLL, I will usually fuse those patients because I worry about OPLL progression. And I don't know, do we know what happens to ossification of the flavum?
You would have resected it. I mean, I would.
You'd also be removing it, right? You'd be actually undercutting the lamina and resecting that nugget of...
Maybe this is my historic, pre-2000 education. Why not just a laminectomy? I mean, so why do we need to do something fancy? Can't we just do a laminectomy of, what was it, 4, 5, 6, and the leading edge of 7, get it completely decompressed? It does not kyphotic. He's a little bit straight there. On flexion,
or without it?
no, just a laminectomy. Yeah.
Do you like the alignment, though, Neil?
How old is this? He's 70.
She's 76.
76. She's got a relatively stiff spine.
She's relatively sick as well. I mean,
Flexion extension. I didn't see any obvious translation. I mean, let's just do a quick and dirty laminectomy.
I mean, everything we learn in training, maybe you can expand on everything you learn in training is never just do a multi-level posterior cervical laminectomy alone. Is that not the case? I mean,
That was not my training.
2-level laminate, not like multiple levels, but just the 2 levels where the ossification
yeah.
I would have no issues doing like a 4, 5, 6 laminectomy, leading edge of 7. You stay out of the facets. And why make it complicated?
And you don't worry about post-laminectomy kyphosis or anything like that?
She's 76.
Yeah, okay.
Yeah, and obviously you have to stay out of the facets. You have to follow these patients, but it's pretty rare in an older, stiffer spine who doesn't have a preoperative kyphosis. She's not kyphotic. She's lost some of her lordosis, but she's not kyphotic. For her to develop kyphosis down the road, that'd be rare.
I've definitely seen that. The only problem that I see with that in this case is she's not frankly kyphotic, but she's almost kyphotic, and her sagittal balance is a little bit positive as well. She's got that old lady head pitch forward kind of thing. Makes me worry a little bit.
Well, you cannot expose the facets at all. It's a very narrow exposure. You're just seeing the very medial aspect of the facet, and you have to really protect those facets. But I think we get away with it all the time.
Vince, you were going to say?
I was going to say, can you show us that MR? I don't know why you do 7. I would take off 3 as discussed, but I think if you just dome 7, you can stay away from 7-1.
Yeah, just don't sell.
Yeah, because your plan had to go to do a 7 laminoplasty too, and I think you can get it all out just doming it.
Okay.
Yeah.
So let's do a little vote of the audience. Can you go back to the options that you showed?
Yeah. Is there any role for an anterior procedure?
Who would vote for plan number 1? Raise your hands. Okay. Who would vote for plan number 2? It's about the same. Okay, but stopping at 7. And who would do an anterior operation?
In the laminectomy alone.
Neil's on that one. Sounds like it's pretty evenly split between plan 1 and plan 2. So what'd you do?
Yeah, so we ended up doing a C4 to T1 posterior spinal fusion, C4 to 7 laminectomy. Easier to line up the T1 screws and rather by skipping C7, and the ossified ligamentum flavum came off pretty easily, but we still had to leave a little bit behind.
Rick, you said you would have stopped at C7?
Oh, it's up C7, but the issue, so we know a lot about OPLL, and we know that laminectomies and laminoplasties, it's like throwing gas on the OPLL fire. I mean, it over time, that OPLL progresses. And my hunch is probably the same thing happens with ossification of the ligament flavum. And even though someone said, well, you're taking it away, this patient still has a propensity, obviously, to calcify the ligament flavum. And I'd be really worried about doing a laminoplasty in this case because of what we know about OPLL.
I agree with you, but I would just say she's 76. How long is it going to take for that to happen?
Sometimes it happens pretty quick. And it depends how much motion. Like with the laminectomy, it happens really quickly. Now with the laminoplasty, there's less motion, so it's not as fast. But
My bet is that a 76-year-old.
she's going to live to over 100. Come on,
not
we're in
this
the new
lady.
millennium. She's going to live to
My
have a
attending described
question?
this lady as having more doctors than any patient should ever have.
Yes, you had a question?
Just a question. I've more recently heard people talking about hybrids doing a laminoplasty infusion on top of it, and patients especially who have poor protoplasm, more so for the fusion rate, so they have more surface areas infused with the top. I don't know if any of you had experience with that, agree with it, disagree. I just wanted to see what your thoughts were.
Yeah, so the question is about laminoplasty with fusion. I do that occasionally, but in my opinion, I do it more because, and I gotta say, I don't have any data to back this up, but I feel like if I do a laminoplasty with a fusion, I do it on people that I think are at higher risk for some sort of major cord drift back, reperfusion injury, or C5 palsy. And in my anecdotal experience, I found if you do that, the cord doesn't drift back as much, and maybe they don't get as much of those complications. Any other thoughts on that?
I'm always curious. I've never done that, but how do you line up your laminoplasty plates? And do you do like unilateral lateral mass screws through the construct? What do you do?
No, it's a little bit finicky because you have to. So what I'll do is I'll drill all the holes for the lateral mass screws, right, on both sides, and then do the laminoplasty cuts, and then start opening the laminoplasty, but don't fully open it yet, but just make sure I can open it. Then while the canal's still closed, I'll put the screws in on the contralateral side, decorticate the facets, put the rods in on that side, and finish that side. Then I open, okay, and then I've got holes drilled on the open side where the lateral mass screws are going to go, so I know where I can put plates. So I put the plates on, then I put the lateral mass screws in, and then complete the open side. So it's a little finicky. Right, yeah. What's that?
Yeah, I've actually used that plate. You can put the lateral mass screws through the laminoplasty plate. Actually, it is a pain in the ass. That plate, it's a pain in the ass. I just want to go back to Rick's point about OPLL. It's, laminoplasty was originally described for OPLL, and then it turns out that because of the persistent motion, you can't get progression of OPLL. The literature I've seen says that it progresses, but it doesn't necessarily lead to any change in myelopathy, meaning it clinically may not matter, but radiographically it progresses. So my question, I think, to the faculty is, if you do see OPLL, do you think you are obligated to do a PCF, or is it okay to still do a laminoplasty?
There's two articles that show that there's slower volumetric progression with laminoplasty than there was with laminectomy infusion. Now, again, a lot of the people who are advocating for that are people who are big laminoplasty advocates. But the thing that there's always this universal progression, and a lot of the patients, of those 300 and whatever that I've done, that there's been 4 revisions, a lot of those were for OPLL, okay? And it's not this thing that you did it and it's pouring gasoline to explode the OPLL, again. So for almost 400 patients, I've reoperated on 4, and I don't think any of them, most of them were for a single level radiculopathy that developed in the mid-cervical area after the laminoplasty. I can't think of a patient where I have done. Now, I will tell you, if somebody's got 80%, canal volume, with OPLL, I'm doing that from the front, okay? But if you have somebody that's under 40% of canal volume, I'm doing a laminoplasty, and I have not had to reoperate on those. But as I said, we have I told you, I said when I gave my talk yesterday, for John who wasn't here, that this is like politics. Who do you support? Are you red or blue? I'm kind of the red laminoplasty, and Rick's the blue, the blue laminoplasty nihilist.
I read the literature.
The other difference is you don't get paid very well doing laminoplasties. That's the big reason why it's not as popular. In reality, you don't get paid anything for doing it. So, you don't have a huge, beautiful building like this.
All right, on that note, let's go to the lab.